As we know, the aneurysm which are less than 3 mm need no much intervention. They don't need intervention to clip or coil unless it is ruptured. So, but these needs to be have a regular follow-up, and the patient need to be educated regarding the maintaining healthy lifestyle or to take care of the diabetes status or the hypertension if at all they have, to prevent the progress of the aneurysm size. Once the lesion is progressing, then we need intervention, otherwise patient can live with the small aneurysms. So once the patient with the brain aneurysms, as we all know, they land up to the ER with either severe headache or vomiting or seizure or weakness in one part of the body, depending upon the amount of blood that has gone into the brain. So once the patient lands up in the ICU, the ER, then we need to first diagnose whether it's aneurysm or not. Usually patients say they had a severe headache. Then we get a regular plain CT brain done to see what's happening there. So usually the picture is there's something called a subarachnoid hemorrhage in the brain. That is the blood gets collected over the layers over the brain. Usually this is the picture for the aneurysm bleed. But rarely around 10 to 15% of patients can have massive bleed into the brain. Once we see the picture of the subarachnoid hemorrhage, then we confirm that it's an aneurysm bleed. So to confirm the diagnosis, then we go for the angios. Either it could be a CT angio, MR angio, or the gold standard is a digital subtraction angio, where we take into the cath lab to get the angio done. Once the angio is done, then we analyze, we as a neurosurgeon or intervention radiologist, we analyze the orientation of aneurysm, size of aneurysm, the anatomy. So depending upon so many factors, apart from this morphological factors of aneurysm, even the patient condition, how bad is pre-op condition, depending on those factors, we take a call whether to what kind of intervention we do. So the golden dictum in aneurysm is that once a patient lands in the hospital and you confirm this aneurysm, the earlier the treatment, the better the results are. So once you delay the treatment, the chance of re-rupture is quite high. Once it re-ruptures, the chance of mortality, that is the death rate, is quite high. The aneurysm is confirmed, then there are two ways of dealing with it. So either way, we need to separate or isolate the aneurysm from the normal circulation. That is either clip it or coil it. So two methods are, one is open method, where you open the skull bone and go in, separate the brain and put a clip there to isolate the aneurysm. The second one is we intervene with a minimal invasive method. Just like how we put a stents in the heart, we go from the thigh blood vessel, reach the brain blood vessel, then they put a coils into the aneurysm, separating the aneurysm. Which aneurysm needs surgery or minimal invasive technique all depends upon the patient condition. Whether he is very good, his score is good, like he's talking, walking, or if he's quite bad, or depending upon the anatomy of the aneurysm, morphology, what size of aneurysm, what is the neck size, how the orientation of aneurysm is, how brain is swollen or it's relatively okay. Depending on so many factors, we finalize, we as a team of intervention radiologists and we neurosurgeons discuss and go ahead to give the best treatment and to do missed complication to the patient.